Hi, everybody. This is Dr. Una. If this is your first time of meeting me, I am the founder of Entre MD, and I help physicians build profitable businesses so they can live life and practice medicine on their terms. And today I have an amazing guest, Dr. Paul Firth, a pediatrician and coding expert out of Oklahoma. And we are going to be talking about how to code those 99214 and 99215 telemedicine visits. They're not all twos and threes. There's a right way to do it, and I don't know anybody better to walk us through that than Dr. Paul Firth. So welcome to the show.
Thank you. I think I'm just going to listen to your first minute every day where you call me amazing and just start my day off that way.
Well, yeah, go for it. But it's nothing but the truth. Now, if you guys don't know, anybody who's coached with me and who's in private practice, I've had them go do your course. I'm like, listen, I'm not talking to you about coding. You need to know this. You need to get it down pat. And this is a course you need to do. So I have recommended your course for for years at this point. So when I say you're expert, I'm not kidding. When I say you're amazing, I'm not kidding at all. But I'll give you a moment to introduce yourself to our listeners, and we'll take you from there.
Okay. Well, yeah, my name is Paul Firth. I've been a private practice pediatrician for about 21 or 22 years. I've lived in the same small town since we started, our practice out of medical school or out of residency. About 6 years into my practice, I started realizing that I had a lot of uncomfortableness coding. I had a lot of fear of coding the wrong thing and fear of not documenting enough and frustration of having to write too many things. And so I thought, if I can learn the Krebs cycle, I can learn how to code, surely. And so I started learning about that. And then basically we started a company called Medical Efficiency Systems about 15 years ago now, where we work with doctors to try to work on just basically how can we streamline our documentation and simplify the whole coding thing so that we get paid for the work we're doing and then maximize our documentation, mainly so we don't have to worry, are we doing it wrong? Are we missing out on money? Are we coding too high and going to get money taken back or lose an audit? Just getting rid of that fear and discomfort of all things coding and financial is huge as far as peace of mind.
Right. And I agree. I know a lot of doctors, the hang up is I don't want to get audited. And so because of that, we're like, we'll just do the threes, let sleeping dog lies and sleeping dogs lie and forget about all that. But once you know how to do it, and I think one of the things that really reassured me when I came to your event in Atlanta years ago was that you had been audited. You talked about it in the event, you had been audited a number of times and all of that stuff. I was like, hey, like, let's do it. You got audited, you survived it nicely. I'm game, so.
Yeah. And I don't want to downplay it. Getting audited is a scary pain in the butt. It is not fun, but it is survivable. And you just do, that's why I tell people, you don't ever try to make anything into a 4 or a 5. You do the work and you see where it falls out, but you want to get credit for what you did.
Yeah. And I love that you say that. So we're not trying to make visits what they're not. We're just coding properly for what we did.
Right.
And a lot of times doctors are doing 99214 work in patients that qualify to be patient visits that qualify to be 99214 visits. We're just not, too scared to do it right. But all
That's right.
Now, before we get into the nitty gritty, I'm curious about your thoughts. There is a lot of people who want to do telemedicine or who are even doing telemedicine that really just feel it's bad medicine because you can't touch the patient. What are your thoughts about that?
Well, I'll admit everything I've learned about telemedicine started 3 weeks ago. 4 weeks ago, I knew nothing about telemedicine. So I'm reading stuff just like you all are. There's this thing of, well, I can't do as good a medicine if I don't touch the patient. But especially people who have been in practice more than 10 or 15 years, you kind of realize that I don't need to touch a lot of patients anyways. And very often I'm in the room, if somebody's got a certain breathing pattern, I can probably tell you pretty close to what they have going on. This looks like pneumonia or that looks like asthma or RSV before I ever listen. And sometimes the listening will surprise me. But for a pediatrician example, if I take out the kids that I don't have to look in their ears or listen to their lungs and I don't have to push on their belly, that's a huge volume of patients.
Yeah.
And there's a tremendous amount of physical exam you do with your eyes and ears, and it doesn't involve your stethoscope or your hands.
I like your perspective. Okay. Love it. Now, so since we're not touching the patient, right, we have a whole chunk of the visit taken out. There's
Right.
no, well, it's not no physical exam, but very limited physical exam. Should they all be 99213s? Or are there still level 4 visits that are telemedicine visits?
Well, the nice thing about the telemedicine codes that we're using now, they're regular E&M codes, 9921, 2345. And there's other telemedicine codes that nobody ever paid for and they didn't pay well. But now we're getting paid for doing basically a 99214 in person or not in person. And the nice thing is the coding guidelines are the same whether you're in the clinic or not. And so it's going to be this 2 out of 3 of history exam decision making. And so there's a certain amount of history we're going to do that's appropriate for the patient. Even though it's virtual, there's a certain amount of exam we're going to do. And then, of course, the decision making. And what I have found, at least with my telemedicine visits so far, is less than a level 4 is pretty rare. It's really hard to make a note that's a level 3 if you've spent 10 minutes with a patient. It's just difficult to do that.
So you're having a hard time doing 99213s.
Right, because they just don't exist hardly.
All right. Well, this is going to be very interesting conversation because I can tell you a lot of people just got very shocked. Like, what do you mean? Okay. All right. So what kind of visits could be level 4 or level 5 visits?
I'll use a typical example from my practice just because it's easier to tell you what I did than make up some example.
Okay.
We do a lot of child psych, a lot of ADD and anxiety and depression and behavior. And at first, the majority of our patients were doing that. Now, it's hard to do a sick kid online. If they're an older kid or they're verbal, you can do it kind of, but you still can't look in their ears. They can put their mouth up, you can look in their mouth, but mainly it comes to more of the non-sick kids. And so our typical one might be, let's say, follow-up of ADD/anxiety/oppositional defiant disorder. And what I do is I actually pre-write my telephone notes before they get there because I'm still getting used to this and I don't want to sound like I'm unprepared. For some reason, if I'm in the clinic with them, it doesn't bother me if I'm unprepared. I'm like, I don't know, let's look. But on the phone, it's like, oh, I better know all this because I'm, the doctor. And so I'll pre-write my notes. And so like it might say, okay, little Johnny is seen via virtual visit with his mother for follow-up of ADD and anxiety and sleeping problems. And I'll put his last visit was 3 months ago. At that time, we stayed on the same doses of whatever his medicines were and made no other changes. And so then I'll go down to my assessment area in the note and I'll say number 1, ADD, number 2, sleeping problems, number 3, anxiety. And then in my treatment plans, I'll put continue this, continue this, continue this. We'll follow up in 3 months. And then when we get them on the phone, I will say, okay, how are things going? And just listen to see what they say. Make sure with virtual visits, you have to talk with the patient. And so for pediatricians, you can't just do it with a mother or father. And so you have to have the patient there. But then once you see them and talk to them, they can run on and do their thing and you can talk with the mother and the father. And for some of our ADD kids especially, it's wonderful not having them in the office. And any parents watching this, you know who you are.
We won't tell them you said that.
That's right. But then like on history, the history's simple. Usually I ask, how is he doing as far as his behavior, his impulsiveness, his anxiety, his sleeping? Are we having any side effects? And so depending on what medicine they're on, any weight changes, any appetite, any, whatever. And then by the time I put that into my note, it's very easy to get a level 4 visit. Do we want to talk about level 4s, what that means right now or what?
You can.
Okay. Here, let's see. We got a slide in here.
Okay. Let's see.
Let's just do the E&M slide.
E&M slide?
Yeah.
Okay. I'm going to do some test runs because is that the one that has the risk or 99214 and 99215?
Yes, that one, the 99214 and 5.
All right.
All right.
There we go.
So if we look at this slide, this is from the E&M guidelines, the 95, 97 guidelines on CMS's webpage. And basically on the 99214 side, we have to have 2 out of 3 history exam decision making. And so obviously with telemedicine, we're going to have less exam than we normally would. But very often, especially with chronic problems, you don't need any exam to get up to level 4. For example, this kid I just did, I'll have a chief complaint. This is why they're here. For HPI is very simple. Here for follow-up of ADD, anxiety, sleeping problems, was last seen 3 months ago. He's taking these medicines. Here's what's going on with his symptoms. I've got at least 4 elements of HPI with
Yeah.
location, duration, modifying factors, and exacerbating. And then to get 2 review of systems, that's usually come from the questions I've asked about side effects of the medicine. Any weight changes, any sleeping problems. Well, that's GI and constitutional. And then 1 element of past medical, family, social history, which if their problem list and med list is in there, you're done. And so that little bitty history that we did that took 30 seconds, that's a level 4 history. The only way to knock it down to a level 3 history is I need to quit asking questions like, are the medicines helping? And
Right.
that doesn't make for a very good visit or very good healthcare. And so it's a very minimal amount to get that much history. And then, for example, with decision making, you have to have at least 2 out of 3 of diagnosis management options, data review, and risk. We're not going to go into great detail about these, but for example, with this kid, he has 3 stable chronic problems, which will be 3 points for diagnosis management options.
Yeah.
On risk, he has at least 2 stable chronic problems, which means he has a moderate level of risk. And so if you see somebody for follow-up and they have 3 chronic problems, you already have a moderate level of decision-making no matter what. And so no matter what his exam was, just that little bit we commented on, that is a level 4 visit. And then exam, you just add into that.
Right. So that's an easy 99214.
Easy,
Right.
easy.
Okay. So that's for an ADHD with sleeping problems and all of that. What other kind of visits could be a level 4 visit? So say I'm a pediatrician, or maybe I'm even med peds, so I do adults and kids, and I'm going like, well, that's great. I don't see ADHD
Right.
patients. What other kind of visits would be 99214 or could be?
Well, what we do at least is almost anybody that you're telling come back in a month or 2 or 3 months for a follow-up. Usually that means you don't need to do an acute belly exam or an ear exam on them. And so, for example, I had 2 siblings. I thought they both had ADD. That's a good a doctor I am. And they lived an hour away. And we did the first one and he had ADD. We talked about it. The second one, I said, well, how's he doing? And I was starting right then for the first time. I looked at his chart. It says asthma, allergies, eczema. He's on albuterol and Flovent and some other things. And he doesn't have ADD at all. And I was like, oh, I didn't really mean to do this. But I say, well, how are things going? He's doing fine. How's his breathing? Good. How much albuterol is he using in the last week or 2? Once a week, maybe he's sleeping good, no coughing. Okay, do you need refills? Let's continue on your same medicines. And in exactly the same way, and I could see him where he's talking, he's not out of breath, he's having no distress. And just like the previous visit, that was a level 4 history. And that was a level 4 decision making, no matter how much exam we did. It's just a 4 by its very nature because he has 2 or 3 chronic problems.
Got it. Okay. All right. Perfect. Now, how for someone who is adult medicine, so what that would mean is if you have a kid who has if you have a patient who has hypertension and high cholesterol and diabetes, that there's a potential for that because they have 3 chronic problems. How about if they have exacerbation of a problem or any of those kind of things?
Yeah, I mean, what we do on that is, again, you want to pre-write your phone note and look and see who this patient is, what's going on. If you did labs last time, make sure you know the results. You can discuss the labs. If they have something like, let's say, hypertension, diabetes, make sure that you let them know, hey, before the visit, check your blood pressure, check your sugars. I want to see what your sugars are doing and if you've got a blood pressure log. And you make sure they provide those things if they can. But then often when you're seeing the patient online, you get a good feel for either, yeah, let's do this, and this, and we'll see you in a month, or we'll do these labs. Or you pretty quickly get a feel for, I need to take a look at you. I actually need to physically put my hands on you because there's things going on that I don't know I can manage over the phone.
Yeah.
And that's easy. You just stop the phone visit. And what we do is we don't charge them for that if we immediately tell them to come in. You have them come in that day or the next day and you do what needs to be done. Or you might say, oh, you know what? You need to go to the emergency room, or you need to go to urgent care, not wait for tomorrow. We had a kiddo yesterday, he needs some simple labs, and they lived, 40 miles away. And so I said, hey, we'll send the lab orders to your hospital and you get it drawn there, and then we'll touch base in a week.
Right. Okay, great. Great. All right. So you had another slide on the risk. Did you want to go through that?
Yeah, we can talk about it just briefly. This is not a comprehensive slide of risk, but the risk slide, this is from Medicare/Medicaid. This is what they use for risk. A lot of people don't understand risk, but to get a moderate level of decision-making for a level 4 visit, you kind of need a moderate level of risk.
And can you see the slide? Is it coming up?
It's
okay, hang on. Hang on. I'll stop the share and. There you go.
Okay, risk, this is something that is made by CMS, the government, and it's very objective. You don't get to decide how risky somebody is. But usually for a level 4 visit, it's nice if they have a moderate level of risk. And it's real simple. If they have a chronic illness that's not completely, entirely well controlled or has side effects, that's at least moderate risk. If they have 2 stable chronic illnesses, which is every adult doctor I've ever seen has patients with 2, automatically that's a moderate level of risk, no matter what else you do. But again, if they have an acute illness with systemic symptoms or a complicated illness or injury, or if you do prescription drug management, which means making a change on any of their prescription drugs, or starting a drug like this person needs amoxicillin, all those immediately get you to moderate risk. It's very easy to get to. Now, on the same time, we talk about level 5 telemedicine visits, and people are going, level 5, there's no way you can do level 5 visits. That's impossible. And it's really not. You can do level 5 visit just like you can do a level 4 visit in the office. The difference is, if you look at risk for level 5, it says that your chronic illness with severe exacerbation or illness or injury that threatens life or body function or an abrupt change in neurologic status. These should not be done on telemedicine unless it's on their way to the ER. Right. And so we don't really get the advantage of risk. But if we talk about level 5 visits, let's go back to the other slide we had.
All right, I'm gonna. It's up.
Here is how I end up getting some level 5 visits in my office. If you look at the level 5 column, it still needs 2 out of 3 of history, exam, and decision-making. The big difference is in history, you have to have at least 10 review of systems. And so that's a lot. You have to actually sort of march down a list. Here's what I'm going to ask about 10 systems. You have to have 2 elements of past medical, family, social history, which usually means you have your problem list and med list. That's medical history. And at least one other question from social history, like smoking or drugs or whatever, or at least one other question from family history, like family history. But it needs to be pertinent to the visit. If Grandpa Joe died of a heart attack, and we're seeing this patient for something that has nothing to do with that, that's not always appropriate. But if I'm thinking about starting somebody on an SSRI, well, whether anybody else in the family has tried this one or had a good or bad response, that is an important history. Then exam, you have to do a comprehensive exam, which is 8 organ systems, which is actually pretty difficult to do online. And so I don't really recommend that. So really for a level 5 online visit, I'm looking at 10 review of systems that are necessary. I just don't want to ask 10 just to ask 10. They need to be important to the patient. 2 elements of the past family medical social history. And then on decision-making, I need 2 out of 3 of diagnosis management options, data review, and risk. Now, like we just said, it's going to be hard to get a high level of risk over a virtual visit. So if we look at the other 2, diagnosis and management options, the way you get 4 points is you can have 4 chronic problems that are fine. You can have 2 chronic problems that are not fine, or some combination of that. Or you can have a new problem where you have to do additional workup, such as anything that you need to order, labs or radiology or diagnostic procedures. And then data review of 4 points. The easiest way to get that is, you get a point if you do any kind of lab. You get a point if you do any kind of radiology, a point for diagnostic procedures. But a big one, especially for pediatricians, is you get 2 points if you summarize the history from somebody other than the patient. For example, I actually did a level 5 virtual visit last week. And I know you're thinking, oh, I'm going to tell. And here's what happened. I saw this mom, she brought in her 2 kids for well visits on a Tuesday. And we did the well visit. The one kid was off the wall, nuts. I mean, he was just everywhere, where we had to take all the chairs out of the room. We had to take all the toys out of the room. And I said, well, let's come back in about, 6 months or whatever. She said, oh, no, I've got an appointment with you on Friday because we're going to get him worked up for ADD. And I thought, thank you, Lord, if we could, so we can do this. But she was coming on Friday, and I thought, okay. I said, how about this? Let's get you set up on the portal, and we're going to do that virtually because they live 20 minutes away. And I said, let's just do this online. She's like, we can do that? Sure. And so we sort of, when we work up behavior, we have the standard review of systems. We ask about how they're sleeping and how they're eating, and it's 10 or 11 systems, but it's pretty structured when we work up behavior. But then, like, for example, on diagnosis management options, we had a new problem with additional workup. With this particular patient, we did some screening lab and we did an EKG for some other reasons. And so I got 4 points for diagnosis and management options because it's a new problem with additional workup. I got 2 points because I got the history from the mom. I got a point for doing lab and a point for doing the EKG. And so just with that much, no matter what I put on the exam, that is a level 5 visit. Now, again, I don't do things to make it into a level 5. I do the visit, write it down, and it is a level 5. And so that's the appropriate way to bill for it.
Right. Okay. So 4s, very common. 5s, very possible. And we should not be doing all level 3s. Now, there are some things that are 3s, but because we're not making this up, but it's important for people to see the potential. Okay. Now, I know you did a really good job explaining this and all of that, but for the people who are watching, if you're finding that, wow, even the visits he's been describing, when I see them in the office, I am even doing those as 99213 visits, then I really want you to go and get his course. I linked it to our site. So entremd.com/coding. And you can get that course. It is all online, so your social distancing will be intact. And but it would be a game changer for you, because even at this time when our volumes are being heard and all that, the last thing you want to be doing is under coding. So check it out, entremd.com/coding. The first time I did his event was probably 2011 or so in Atlanta, and everybody who comes into my office, who comes in, a doctor, nurse practitioner, any of those, they're all required to do it because it literally is a game changer. All right, so let's talk a little bit about physical exam, since you can't touch the kid.
And we do have one more slide. Let's pull that one up.
All right, let's do it. There we go.
Yeah, this is what I just call some no-touch physical exam. These are actually bullets from the 1997 guidelines published by CMS. And often they are very helpful when you're trying to decide, what did I do? And so I put these in my templates to sort of prompt me to say, okay, did I do this? For example, constitutional. Are they normal appearing? Are they overweight? Are they underweight? Are they, do they not look normal in some way? Put that down. On their eyes, I mean, and this is not required, but if they have normal eyelids, normal conjunctiva, or not, because somebody's calling in with pink eye, that's a bullet for the exam. If their external ears and nose look normal, that's a bullet for exam. Now, respiratory, obviously we can't listen to people.
Yeah.
But saying that they are non-labored or no acute, the bullets actually say if their breathing is labored or non-labored. And so that's what we put in our templates. Their breathing was non-labored. And you think, well, that's not important if they're here for a psych visit. Well, it is if it's labored. And so that's part of your exam. Same musculoskeletal, if you see them walk around, normal gait, normal station. But then for the psych exam, there's several parts of the psych exam that are easy to put on there, such as normal judgment and insight, if they're oriented, if their recent and remote memories intact, if their mood and affect are happy, sad, joyful, fearful, whatever they are. And that's what we found is we had one patient call yesterday and said, hey, we've got this rash on our scalp and it's not getting any better. Can we come in? And we tried to get them to do it virtually because they thought, hey, I can look at a rash on the scalp. That's pretty easy. And they just want to come in anyways. But something like that where you can definitely document abnormal skin areas where the parent shows you, here's what's going on.
Yeah.
It gets pretty easy to do that. But again, even if somebody comes in for a semi-acute visit, hey, I'm coughing and congested and this kind of stuff. Once you get through asking them questions, diagnosing them with, fever or upper respiratory infection or whatever it may be, doing your things despite not having a very big exam, often your history and decision making are already enough for level 4.
All right. So we're focusing on the history and decision making, and then we're doing as much as we can of a limited
Right.
inspection
Yeah.
based
Don't forget the
exam.
exam because it is important.
Yeah. Okay. All right. Really good. All right. Well, this I think was really helpful. Um, so we can start thinking about things differently. I had some, colleagues who were doing mostly twos because they're like, it's telemedicine and, we can't touch the patient. So it should be a two. And, I really want doctors to be able to code properly for what they do. Most doctors are great helpers. So we do a lot, a lot of
Okay.
work, and we don't need to overcode like you said multiple times, but we do need to be coding for what we're doing. So thank you so much for coming
Thank you.
on to share this with us. Please, people, if you're listening to this and you're excited but you're nervous and you're like, I don't know enough about this, do check out his course. Do get it. It will change everything. It will be the best $325 you've spent in a long time. Okay.
All
So
right.
thank you so much for this. And hopefully we'll get to do something else in the future. This was really, really helpful.
Thank you. This was fun.